All right, everyone, welcome. I'm Chandra Vemulapalli. I'm an orthopedic trauma surgeon at Tulane, and I work at University Medical Center in New Orleans. And I'll be presenting on behalf of CurvaFix today on an elder acetabulum fracture. And so today I really want to highlight this patient. And so this is a 71-year-old male who fell while roller skating with his ex-wife. And he has this past medical history, which is not particularly relevant to our conversation, but for completeness sake, he has a history of prostate cancer, and you can see the radiographic evidence of his treatment on his image. He had a previous CIA with no deficits. He has hypertension and otherwise is a very active and healthy individual as an active fisherman. He lives alone and runs his own business, actually repairing and constructing around that part of Louisiana that he lives in. And so after his fall, he sustained this injury that you see on the screen, and has this minimally displaced left acetabular fracture. However, he was evaluated at an outside hospital with significant pain, unable to mobilize and ambulate, and such was transferred to our center. After we evaluated him, he had continued inability to ambulate secondary to pain over sequential days, and was very frustrated with his progress and very concerned about his loss of independence and loss of ability to do the things that he needed to do, as he was still significantly involved in his community as well as in his work life. And so the objectives that I want to really highlight for this talk is indications for how you treat this patient, if you're going to plan for operative management, how I go about my preoperative plan, how I executed that plan, and also how I have found to navigate some of the challenges of navigating some of these types of injuries, and particularly with use of the CurvaFix implant. And so once again, you can see the image of our patient. You see the disruption of the iliopectineal and ischial lines. However, he does not have significant articular displacement. However, the major concern for this patient is, given his level of independence and inability to mobilize, was pain control and the ability to weight bear is tolerated immediately. This was very important to this patient. He was very adamant about it. As I really tried to talk this patient not operative management, but he was not interested and was very much looking for a solution. And so I think this is one way that you can address these types of patients, particularly as we continue to prioritize mobilization in these elder patients with poor bone quality. And so to highlight his injury and the different planes of fracture planes that we'll see here. And so we scroll down, you can start to see the anterior column fracture plane as it continues down to the articular surface with minimal dome displacement and a little bit of comminution around the root of the ramus as well as the quadrilateral surface, but nothing too involved here. He still has good pathways for percutaneous stabilization, which is what our surgical plan was for this patient. And so here are some 3D images, just once again to show the surface morphology and the primary areas of displacement of his injury. And so when I see this image, my initial thoughts are, where do I need to stabilize and what are my opportunities for fixation? And so his majority of his displacement is really at this pelvic brim fracture line, separating the anterior and posterior columns. So something to stabilize the anterior column to the posterior column, as well as to fortify this ramus region, and then also potentially placing fixation from anterior to posterior, I think would give me multiple planes of fixation to give this patient a stable construct to allow him to weight bear is tolerated immediately. And so those are all the things that I'm considering as I'm going forth into the operating room to execute my plan. And so here are some initial floor images, an AP, as well as an iliac oblique and then an obturator outlet. So you can also see the patient's osteology and see that it's particularly for his ramus pathway, his anterior column pathway, he has quite a significant curve, which can be challenging to navigate with straight implants. So given his primary displacement, I chose to start this with fixation of his anterior column to his posterior column. And so this is an iliac crest, a posterior column pathway. And so these are just some images of the initial guide wire placement. And so you can see on the iliac oblique view that it's a slightly more anterior start point along the pelvic brim, ideally centered within the gluteus medius pillar pathway. And if you get an obturator oblique view, sometimes in the right patient where they have a wide enough pathway, you can actually visualize the anterior and posterior cortical limits of that pathway to ensure that you're well centered where you'd like to be. From there, there's a passment of the flexible guide wire with the ball tip and the sharp tip to it. And these are the placements that you're looking for. On an AP view, you want to be just lateral to the ilioischial line into the ischium. And then on the iliac oblique view, posterior to the articular surface to ensure that your placement of implant is extra articular. Then from there, the path from the flexible reamer will also show you where the implant should go. You can see that even as you expand this pathway, it continues to stay extra articular, does not violate any of the joint surface. One thing that I have found helpful is that the crest can be a somewhat prominent area on patients, as you can usually readily palpate the iliac crest on yourself or on most patients. And so countersicking this region, I think, is a helpful thing to make the larger proximal diameter of the implant a little bit less prominent. And then from there, you can see the placement of this implant from the iliac crest all the way along the posterior column with its ultimate ending point into the ischium. From here, the next planned area of stabilization is the anterior column. So we really address the posterior column and in some senses part of the anterior column. However, you remember this patient also had fractured planes along the ramus that are not addressed by the initial fixation implant placement. And so you can see here the opening reamer for the proximal portion of the pathway. And you can see that our trajectory here is pretty good. And so even in this curved pathway, we're able to hit a fairly straight shot down this corridor. And a good way to navigate that I have found is the aid of this drill tip wire. And so this wire is not only helpful if you already are in a good trajectory that you don't feel like you have to navigate much more with the aid of a bent wire, but also it is very, very helpful if you want to place bicortical fixation, as placing the sharp tip, ball tip guide wire bicortically can be a challenge. But this drill tip wire makes it quite a bit more simple. As you can see that this is a bicortical placement of the pathway that then allows you for an accurate depth assessment of your implant size. And then as you ream and apply your implant, you can see that you can accurately size this to place it just bicortical into the pubic tubercle region to fortify the fixation of the anterior column and ramus region. Now, you'll also note that on the obturator outlet image that there's still a sliver of space available at the AIS for placement of a pelvic brim screw back into the posterior ilium for an additional plane of fixation. And so that's where I then directed my attention. And so this is the wire placement on the obturator inlet view, as well as on the iliac oblique. And if you want to, you can then confirm the placement of that wire on obturator outlet view so that you're within that triangular area that you still have available to you. And so this is a way that you can learn to navigate intersecting pathways, as there's only so much space to work with. But with well-planned placement of these implants, you can achieve all of what you want to achieve with good imaging and good technique. And so this is now our final construct. And so you'll see the crest of posterior column fixation, the anterior column fixation along the ramus, as well as this brim screw from the AIS back to the posterior ilium for 3 separate planes of fixation of this fracture. You can see how all those intersecting ossifixation corridors have been filled with our metallic implants in order to stabilize this fracture. And this is our final AP image. Here are the postoperative axial images. And so the first thing that you'll see is the brim screw from the AIS all the way back to the posterior ilium, now intersecting with the posterior column fixation and the anterior column fixation. You can see that all of our implants are extra articular and contained within our ossifixation pathways and just bicortical where we want to be bicortical, and we can achieve that. And so this is the same patient. I just saw him back in clinic a couple weeks ago. He is back to doing everything he wants to do. He feels great. He's been back at work from about 1 week post-op. And these are his x-rays showing not only maintenance of his fractured plane alignment, but also healing at his fractured planes. His only question to me was, when can I go roller skating again? And I told him, that's not really a good question to ask me. You can decide that on your own. And so to review our objectives, the indications for operative stabilization of this patient is immobility and pain. However, this has to be an individualized patient discussion. This patient is very physiologically young, extremely active, very worried about the loss of independence and loss of revenue that he may incur from having to recover from this injury. And all of those things played into his operative decision making and our decision to honor that and stabilize him. As you go about your preoperative planning, it's extremely important to evaluate the patient's ossifixation pathways, what's available to you, what their anatomy is, how curved are they. If you plan to place multiple implants, are your pathways going to intersect, and how are you going to navigate that? But with a good plan, You can execute that by connecting the ossifixation pathways to obtain multiplanar fixation to give your patient the most stable construct and allow them to achieve the goals that they have for themselves. And hopefully throughout the course of this case presentation, you've also learned how I choose to navigate some of these challenges, and hopefully these tips can be helpful to you moving forward. Thank you all very much and hope you learned something.